Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, October 29th, 2024, we are speaking with Dr. Ken Sherman, Director of Clinical Trials Development at Massachusetts General Hospital and Harvard Medical School. Dr. Sherman is also a distinguished research and emeritus professor at the University of Cincinnati, where he was director of and chief of the Division of Digestive Diseases for many decades. His research interests center on pathogenesis, evaluation, and treatment of liver disease in those with immunosuppression, including HIV infection and organ transplantation. Today, Dr. Sherman joins us to answer the question, will we ever have a cure for hepatitis B? Ken, welcome to the podcast.
Thank you. Delighted to be here, Mike.
It's great to have you, and we got a lot to cover in about 25 minutes or so, so let's dig right in. In order to, I think, understand whether a cure is possible, we have to understand a little bit about the life cycle of hepatitis B, so maybe you can take us through that in broad strokes.
Sure, happy to do so. So the virus is generally thought to be transferred in blood and works its way to the liver. And in the liver, it encounters the hepatocytes and specifically binds to a receptor, the sodium taurocholate co-transporter peptide, which is actually meant to help trap bilirubin and bile acid products and bring them into the cells. So it's a brilliant use of a receptor biovirus for a different purpose. The virus enters the hepatocyte, uncoats, and releases something called relaxed coiled DNA. And that's transported by an active process into the nucleus, where it's converted into cccDNA, or covalently closed circular DNA, which is essentially a mini chromosome. And that mini chromosome serves as the template for transcription of RNAs that go on to make new hepatitis B surface antigen, the X protein, which is a trans-activating protein thought to be involved with development of liver cancer, as well as pre-genomic RNA and the core, of which a component is a secreted product when replication is active that we call e-antigen. The pre-genomic RNA also is packaged eventually after it leaves the nucleus with a reverse transcriptase or a polymerase, but it's a reverse transcriptase, gets packaged and gets converted back into a relaxed coiled DNA, so RNA to DNA, and then gets further processed and packaged, surrounded by the surface antigen and excreted from the hepatocyte. One of the key features of this life cycle is that there is a tremendous amount of excess surface antigen produced, which for many years was regarded as either a decoy or just an expression of excess protein that wasn't needed. But as we'll talk about as we go along, it's become more and more clear that excess surface antigen protein actually plays a key role in the maintenance of chronicity.
Yeah, so what's, I think, really important as we go forward, as you said, understanding the life cycle gives us the targets for where cure can evolve. And I think also for clinicians, we're used to measuring surface antigen. We're used to measuring HBV DNA. And what's important in what you just said is that the surface antigen is coming mostly from the cccDNA, whereas the HBV DNA is coming from a totally different location from reverse transcription of that mRNA. Did I get that right?
Well, it's all coming off the cccDNA template, but they're different strands of it because the virus is a partially double stranded virus containing its own replication polymerase.
So, where are the targets currently being evaluated for getting rid of hepatitis B? What are the cure strategies that you think are most exciting?
So, obviously, this complicated life cycle leads to a variety of potential targets, and those targets start at the stage of binding, and we do have products, particularly one that's Mircludex B or Hepcludex that can limit that binding. But that by itself will not lead to a cure. The areas that, if we think of them today as primary, are probably related to RNA interference. And RNA interference can be further divided into gene silencing, so RNAs that cause a post-transcriptional gene silencing and products that might do that, and then antisense oligonucleotides. Both have been shown to significantly decrease levels of replication, though to date not sufficiently by themselves to lead to high levels of cure, or at least functional cure. We should probably stop for a second and define cure,
Yeah, let's do that.
because true cure involves actually clearing cccDNA. And other than in a theoretical sense, using CRISPR products that are really not at a stage of development that allows us to do that, we're not able to directly clear cccDNA. So instead, the target of opportunity at this point has been what we call functional cure, which is primarily defined as the loss and clearance of both hepatitis B surface antigen and hepatitis B DNA from serum. So with that, we know that people, as long as they are not immunosuppressed, they can probably go years to decades without any active hepatitis B infection or replication going on.
Well, coming back to the CCC, if this were like, let's say, hepatitis C, where the virus sort of exhausts itself and it's actually ongoing replication, that when you stop it, the virus is more or less clear because it's not integrated into the nucleus like hepatitis B. Is there any way just to sort of, if we were to interrupt replication 100% for hepatitis B, would the cccDNA ultimately die off as hepatocytes turn over, or does it replicate with the hepatocytes themselves?
So we think that eventually it will be cleared from the hepatocytes, but that could take many, many years of turnover for that to occur. Remember, hepatocytes divide and replicate their nuclear products. So, at the minimum, that cccDNA is transferred to one of those progeny going forward, and we continue to see it. It appears that it's going to take more of an immune component to help clear those cells completely. And from looking at newer novel markers like pregenomic RNA, we know that there's often very low levels of ongoing transcription from at least some of the cccDNA, even following the clearance of surface antigen. So we do have this long-term latent mini chromosome that, while the mechanism is slightly different than what's seen in HIV, leads to similar problems in terms of difficulty towards cure.
Towards real cure. And I was just going to say, it seems like this is much more like HIV than, say, hepatitis C, which in
Yes.
comparison is much easier to cure.
Yes, we wouldn't have said that a decade ago, but because there took so much time and so much effort to get us to that point. But the reality is that now looking back, Hep C was easy. Hep B looks hard.
Okay, so let's continue the conversation, I guess, focused mostly on functional cure, because that seems more within our grasp right now. You mentioned the RNA silencing. We're using tenofovir products for HIV, and they have some benefit that translates over to hepatitis B. How exactly does that intervene here, and can that be used to contribute to a functional cure?
So the nukes, nucleotides and nucleosides, are able to inhibit the function of the reverse transcriptase step. And that does effectively lead to viral suppression of replication, which is actually much slower process than occurs with HIV. In fact, in duly infected patients, it's not uncommon to have completely undetectable HIV viral load while still seeing significant levels of hepatitis B viral load. But over time, products that are in current primary use, which includes entecavir, TAF, and TDF, will all lead to suppression in the majority of infected persons, but you're still left after a year of treatment with about 8% of those with HBV HIV co-infection who still have detectable HBV DNA.
And as I alluded to earlier, tenofovir and entecavir, et cetera, do not really have any impact on surface antigen production, correct?
There's often, after initiating treatment, a modest decrease, and then it levels out and appears to reach a plateau. And so ultimately, if we talk about functional cure from the nukes alone, it's pretty uncommon. At 5 years, 4 to 6% perhaps will achieve a functional cure, and maybe 1% or so a year after that. So, I mean, the majority after decades will remain infected even after being virally suppressed.
So other targets, we have the nukes, non-nukes, and we have the silencing of RNA.
Right.
You also mentioned entry, but that's assuming that there's ongoing replication. So it sounds like the CCC DNA is much more problematic in this regard, and maybe that entry issue is less important, perhaps. Other things that can attack the production out of the CCC DNA.
So other than cccDNA, because nothing else is going to really get the cccDNA. As I mentioned earlier, Cas CRISPR strategies that sort of reach in and snip it apart at key sites have shown some utility in both cell culture models and humanized mice models, but targeting is very much an issue, and we're just not yet there technologically in terms of getting that to the right place in the nucleus of hepatocytes where it can do that kind of work. I see that as a future therapy or part of a therapy. So where we stand today, I think that the RNA interference, whether it's siRNA or antisense oligonucleotides, uh, appear to be the most promising backbone of therapy. But as I said, they're probably not going to get us there by themselves. The best data we have comes from one of the antisense oligonucleotides. There was a large study of a drug called bepirovirsen, and at the end of that study, about 9% achieved a functional cure in 24 weeks. So compared to what we've had before, that's a pretty excellent result and very promising. In terms of being the answer by itself, probably not. So then that brings us to what else can we do? There's a lot of interest in what are called the CAMs, which are capsid assembly modulators. They're also called occasionally CPAMs. The terminology gets confusing here. Capsid protein allosteric modulators. CAM is easier to say.
Yep.
And those molecules are divided themselves into two classes. One of them, class 1, are molecules that appear to lead to problems in the capsid development. And the class 2 molecules actually make normal capsids that are empty. So you form a normal capsid, but there's no nucleic acid in it, so it's not an infectious particle. These agents in both class 1 and class 2 have been shown in phase 2 human trials to be very effective, either singly or in combination with the nukes, to reduce or totally suppress HBV DNA. But when stopped to date, the virus comes back.
Yeah.
So we're not achieving, again, a functional cure. So for that reason, there's a great deal of interest in, well, we get functional cure with RNA interference. We should combine it with CAMs. And there are studies beginning to look at that. There's some other strategies. The next step would be some sort of immune modulation. That could take a variety of forms. The easiest, though perhaps the least popular, is to add a pegylated interferon, sort of a back to the future approach, because that's where we started with treatment of hepatitis B back in the 90s, and did have some success achieving levels of cure with 48 weeks of therapy of 5, 6, 7% functional cure levels. What if we combine that with RNA interference? And there are many people that advocate a return to use PEG interferons, also combining them perhaps with nukes to maintain really excellent overall HBV replication suppression along the way. Another approach is a renewed interest in monoclonal antibodies. Monoclonal antibodies have been developed and attempted as therapeutics in Hep B for many years, and by themselves proved less than optimal in achieving any targeted goal like functional cure. But this takes us back to, what does surface antigen do? So, what we've learned in the last few years is that excess surface antigen produced by Hep B appears to be a potent modulator of immune exhaustion. Through PD-1 pathways, it basically lulls the T cells to sleep, and that's a normal process at the end of an infection. You want your T cells to go back to sleep rather than keep producing an active response that can lead to autoimmunity. But Hep B has adopted this mechanism that basically says, don't worry about all of that hepatitis B surface antigen floating around, and therefore it it limits specific T cell responses through that mechanism. If we can use a monoclonal antibody to drive down surface antigen along with some mechanism of RNA interference and one or more other mechanisms, then the immune system may become awake enough that it says, oh, I see what's going on here. I can finish the job.
Got it. So let me clean up a couple things. I think for some folks listening may not know what CRISPR is. It's basically molecular scissors, right? So you're talking
Yes.
about introducing that to chop up the cccDNA and make it non-functional. Um, in regard to the um, oligonucleotide, that's a small peptide of sorts which it has to be delivered by sub-Q injection, or how is that? You can't give it orally because it'll get destroyed. So is that typically what's done?
Currently, they've been infusions or injections for agents like that.
Okay. And then for monoclonals, I'm assuming that these are, as you're alluding to, directed specifically against surface antigen. So it's like giving monoclonal surface antibody. Is that right?
Right, exactly.
And it just like decreases the total volume and therefore, as you said, allows the immune system to wake up. It is, there are a lot of similarities. We've learned a lot from studying these other viral diseases, like you said, going back to pegylated interferon. Um, we might see it here. A lot of side effects. People don't like taking it, so it's like usually no more than 48 weeks.
That would bring us to the next method, which
Okay.
is instead of using a peg interferon, perhaps we can use a TLR agonist. And people have had great interest in both TLR7 and TLR8 agonists that stimulate interferon responsive genes, but don't necessarily give you those side effects associated with peg interferon. Again, used alone, they provide us with some markers of biologic viability towards that end, but by themselves do not appear to move us any closer towards functional cure. But in combination, they may do that.
Mm-hmm.
And, and the final one would be therapeutic vaccines. There's been great interest in therapeutic vaccines for probably 15 to 20 years. And overall, the studies tend to start with great excitement. Can we wake up the immune system to antigens that it doesn't normally see? But when tried, again, while there's evidence of some biologic effect and development of specific immunity, it hasn't led by itself to functional cure. But if those can be combined with RNA interference and CAMs, perhaps that will be the final link to get over the top and greatly increase the percentage of cure.
So when you say TLR, you mean toll-like receptors,
Correct.
and those are they have different numbers associated, and as you alluded to, may have be a substitute for interferon and therefore spare people the side effects.
Yes.
Okay. Well, as I expected, two things. One, our time has gone by very fast, and it's a complicated discussion because, as you said, the life cycle of HBV is so complicated. That's opportunity in terms of directing therapies, but it's also complicated in terms of finding the right combination approach, which I'm sure will keep everybody's hands full for at least another 10 to 15 years, sounds like.
I think I would like to optimistically think we're on the lower end of that estimate. We are seeing later stage trials in progress or getting started, and knowing that they're hard to enroll and may not arrive at perfect dosing early on, I'm thinking that we're probably 2 to 3 cycles of clinical trials away from combinations that may give us a big boost in response. I would hope that we get to the 40 to 60% level within the next 6 years or so. And I bet it will be a decade before we approach closer to the 100% mark as we
Well,
have with hepatitis C.
that is exciting. And do you anticipate that complications of Hep B will disappear or become markedly reduced as we do a better job getting functional cure? That is, reduced incidence of cirrhosis, reduced incidence of hepatocellular carcinoma?
Well, we already know that if we fully suppress HBV DNA with the tools we have at hand, we can reduce fibrotic progression and risk of hepatocellular carcinoma. So even today, we have tools in hand that are not being fully employed globally on the people that would benefit from them most to help us. They do require daily medication use. There are certainly barriers to doing that on a global scale, but the benefit is worth it because there's 254 million people chronically infected with Hep B, and at some level, all have risk of disease progression and liver cancer.
So, translating just to practical terms, once you start someone, say, who's not HIV infected, but someone who you're just trying to treat their hepatitis B, if you put them on a drug like TAF or TDF, the tenofovir, you would continue indefinitely. You wouldn't just stop after some a priori uh, time frame of 1 year or 2 years. Is that your thinking now?
So there's a considerable interest in identifying those that we can stop, and there are studies that suggest that after a person achieves functional cure, which will not happen in a lot of cases, then you go through an additional period to help turn that into a durable cure. And that period is probably a year of treatment or more afterwards. Then try stopping. And in those people, functional cure can often be maintained.
Well,
You
that's
can't
good news.
stop it immediately, but
Mhm.
eventually it appears that a high percentage you can.
Well, that is good news. And I guess we'll finish also on a positive note that's stating the obvious, but it's a whole lot better to prevent hepatitis B than to treat it. So, a plug for vaccines to virtually everybody, right? I mean, there's not a good reason not to get a hepatitis B vaccination series.
Absolutely. And in fact, there is some exciting new data regarding the use of CpG adjuvanted Hep B vaccines, which appear to yield extremely high rates of primary response in otherwise difficult populations to appropriately vaccinate, like those with HIV infection, and also appear to yield very, very high responses in people that did not respond to the earlier versions of those vaccines.
So, we're trying to avoid trade names, but that particular vaccine is marketed as, is that Hepaslav? Is that the same one? Or
Yes, the Hepatitis B vaccine is a CpG adjuvanted vaccine.
Perfect. Ken, thank you so much. You took a very complicated topic and made it understandable, as you always do. And you're one of the great educators in liver disease and viral infections of the liver. So really grateful for you being with us. And hopefully we'll have you back maybe in before that 6-year period where you can give us an update and we can modify our estimates of when the functional cure will happen.
Thanks, Mike. I enjoyed talking with you today. Take care.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.